Hello, good afternoon or good morning depending on where you're participating from. I'm Kinkini Banerjee, the Coalition's Relations Manager for USBC, and I'm so glad to have you join us for a very timely and useful session. This is the 39th bi-monthly Breastfeeding Coalition's webinar. This series is jointly hosted by the CDC's Division of Nutrition and Physical Activity and by USBC. The webinars are held on the second Tuesday of even-numbered month from 2 to 3 p.m. Eastern. The purpose of these webinars is to bring together state, territorial, and tribal coalitions to share best practices, learn of national and state issues, and collaborate. All Breastfeeding Coalition members can join us for the national webinar, and announcements are sent through the USBC's Coalition announcement list. If you're on our mailing list, great. If you're not and you'd like to get updates from us, you could subscribe at www.usbreastfeeding.org/signup. Our national call will be followed by regional calls. Each state and territory has 5 call-in lines to dial in. The tribal region has 20 lines. Your state's designated contributors manage the call-in lines for your coalition. I'll now go over some of the logistical details. All webinar slides, the audio recording for this session, and other handouts and relevant resources will be posted on our Coalition's webinar page. And on the webinar page, you'll also find archives for all of our sessions. So here's how you can get to our webinar page. You can either follow the link you got on the email announcement, or you can go to the USBC homepage, and under the quick links on the right side, you will see the bi-monthly Coalition's webinar, and click on it, and that should get you to the page. For today's session, all participants are in listen-only mode. The Q&A section will be at the end of the presentations. However, you can type your questions anytime during the presentations if you wish, and we will pass them on. And here's how you do it. Go to the control panel to the right of your screen. In case you don't see the control panel, it could be minimized. So see, if you click on the orange tab, you see the control panel should pop out. And scroll down under the audio section, you'll see a tab for questions. And when you click on that, it will open up a box for you to type. So with that, let me tell you about today's presentations. Our first presenter is the inimitable Katherine Shealy from CDC. Katherine will speak about CDC's mPINC surveys and how coalitions and state health departments can use the benchmark and state reports to work with local birthing hospitals and improve breastfeeding care. Our second presenter is Emily Lindsay from USBC. Emily will talk about the role of USBC and state coalitions in the Breastfed Beginnings project, and she has some exciting news for you. So without further ado, I will hand it over to our presenters. Take it away, Kat.
Are you switching it over?
I'm working on it. Sorry, give me 1 second.
Okay.
Okay. All right. Okay, you should have control now.
I have control. There. All righty. Well, hello, everybody. Oh, technology. See if it'll let me actually. Come on.
There you go.
There we go. So Well, welcome to our first webinar of 2013. It's very exciting. Ah! I didn't mean to do that, unless I scream in your ear. What did I do? I just lost it. There we go. Okay, sorry. So today, actually, I'm going to be talking about a little bit different from what the introduction was, because as we were talking about how we wanted to make sure that this was as useful as possible for everyone, I thought I would walk you through a little bit of some of the sort of secret skills that you can gain as you grow in your mPINC data ninjahood. Because one of the things that I have noticed as I've gone around the country and talked with folks about using the mPINC data is there's a lot of fear around using the data. And the reality is they're very, very usable. So by way of example, all of the analyses that are in this presentation today, I did in PowerPoint. I did not open anything else. There is no SAS analysis or anything. And you too can use the internet and PowerPoint. So in case there are a few people here today who do not know about the mPINC survey, just a very quick and dirty bit of background on it, really tying into the Surgeon General's call to action, Action 7, which is to ensure that maternity care practices throughout the United States are fully supportive of breastfeeding, and in particular two implementation strategies, one to accelerate implementation of baby-friendly hospital initiative, and then a second one to establish systems to control distribution of infant formula in hospitals. So one of the many pieces of how we might go about achieving these actions is the mPINC survey, which stands for Maternity Practices in Infant Nutrition and Care. It's a biannual census of all hospitals and birth centers that provide maternity services in the U.S. and territories, and it's been administered in the odd years since 2007, usually at sort of the end of the year. And we like to brag that our response rate is better than the U.S. census. It's actually increasing. So our most recent iteration had an 83% response rate. The survey has 56 items in it, but we don't actually use all of those for the mPINC scores that people talk about. But if you want to know more about the mPINC survey, you can go to cdc.gov/mPINC. But today, what we're going to be talking about is a little bit, so you're familiar with the reporting that we do generally on the mPINC results. So we have the vital signs report, we have MWRs, and the benchmark reports and the state reports that Kankini mentioned, so the benchmark reports that go directly back to the facilities that participated in the survey, and nobody else gets those reports, and the state aggregate reports that are de-identified and provide the data at the state level. And then we've also done a handful of analyses in partnership with state health departments where they are wanting to cut their data a little bit differently, and California is really the most recent example of that, and those are pretty wonderful. But another piece of reporting on the results that many people are not familiar with is very comprehensive tables of the data that are listed by state and facility type at cdc.gov/mPINC. And I always have sort of this extra bullet of more, because the more reporting we can do, the more people can use the data. So today I'm going to be talking about that part at the end, these frequency tables. So just to sort of reorient you, this is a little bit of what the benchmark reports look like, the first 2 pages. And just the slide will advance there. There's the vital signs, sort of on the right, I sort of refer to that as the USA Today version, and then on the left is sort of the more detailed science-y version. But those were 2 pieces that we did a while back in August of 2011 in order to show a little bit of the progress between 2007 and 2009. So the more detail that we're now getting into is here is now where you turn into a data ninja with cookies. But before we get into that, part of the ninjahood is to really start asking, well, who determines what the prevalence is of these ideal practices? And specifically just for today, because we don't have a lot of time and because I want to make this sort of digestible and manageable, really limiting, for purpose of example, to the BFHI practices. So who are the players that decide whether these things happen? It depends on how you look at it. And this blue rectangle square over here is kind of conceptually like a hospital. So you've got some people who have sort of 1 foot in the hospital and 1 foot out of the hospital. The administrators, really, they're pretty much in the hospital or on the left. But then the vertical, the top to bottom, is sort of a chronology. So you start prenatally. You've got sort of your prenatal clinicians, your physicians, your midwives, and your prenatal nurses. And then you've got sort of these other folks that kind of come in and out of the interactions with the mom and the practices at the hospital throughout the pregnancy and the birth and the postpartum period. And then you have sort of other folks who really are primarily outside of the actual entity of the hospital, but they actually are very influential. And I think one thing that we often forget about is that moms and their families can be very influential, but we don't really leverage them very often. And I would argue that, in fact, the breastfeeding community has not done enough to help them be a strong advocate for changing maternity practices. But all of these folks have different roles. They have different sort of levels of influence and different leverage points on different kinds of practices. And so in any state coalition or state health department or even community, deciding what you want to do and how you want to get started to improve practices, it's really not a yes or no sort of question. It's what do you want to do and how do you want to change it and who do you want to work with. And so there are a lot of different ways to go about this. So just by way of example, if you look at step 2, train all healthcare staff in the skills necessary to implement the policy, you're going to be thinking about some very different audiences than if you were going to be thinking about, for example, step 4, show mothers how to breastfeed. Right? So for step 2, the moms and their families, for example, are probably not the most influential folks who are going to be able to actually implement step 2. That's much more of sort of an infrastructure, leadership, administration kind of question to make sure that it's part of the expected training that all the staff receive. Step 4, the second example, really that is a lot of that is a nursing care. How is the nursing care provided at the bedside? But also who makes the decision of whether those nurses get the training they need in order to provide that. So you've got sort of different levels that you need to be looking at if you want to go about changing those things. And those questions become really important when your slide advances there. When you want to start looking at your data. So I got anxious. So this is a screenshot of where you find the data. So if you look, let's see if I can use the pointer. If you look over here, if you go to cdc.gov/breastfeeding, up at the top, you'll get a whole bunch of different things. And down on the left over here is the maternity is under data and statistics. You will get the mPINC results. The easiest way to get to this page actually is to just do cdc.gov/mPINC, and then at the bottom of the page it says mPINC results. So there's a lot of different ways to get there. The really easy way is to Google CDC mPINC results, and then you will get directly to this page. So this is what it looks like, and a lot of people get kind of overwhelmed. If this were a live shot right now, I could scroll down and show you just how many tables we have. And people look at this and they say, oh, I can't look at data tables. Data tables, they sound really scary. But I really want to walk you through them because there is an awful lot in here, and it's very digestible, I promise. So by way of example, we're going to look at the table that's actually the newest one that we made for that vital signs report. So going back to screen, that's this one right here. Okay, so this is the one that is actually different from what's in the benchmark and the state reports, where we took mPINC items and we scaffolded onto them some of each of the steps. So each of these columns corresponds pretty directly to one of the BFHI steps. So that's kind of what you're looking at here. And you'll see at the top it says, what is the percent of hospitals with the recommended, basically, what is the percent of hospitals that had each step in place is the shorter way to say this. But being CDC, we have to say it very long and detailed and precisely. So each column, you can think of it as being each of the numbers. So one of the things that you can do to start to get into these data is you can look at, okay, well, what does it look like at the national level? And then you can just kind of pick a state. So if you take just the national level, and this is truly just in PowerPoint, I just took what is the prevalence for each of those and just line them up. So we could take a look at, well, how are we doing? And so what you immediately see is that there are 3 that stand out where more than 3/4 of all hospitals in the country are doing these things. And so that's pretty good. Now, we know that there's a lot of detail under there, and the devil's in the details. But when you're looking at something at sort of this population level and you're trying to decide where should I start, even given sort of the muddiness in what these measures mean, this still says you don't need to start with these. These ones are doing kind of okay. So that immediately knocks 3 out of the park. So if you're trying to decide, so where would you want to get started? So that's sort of nice. It's reassuring. You've narrowed your field a little bit already. Then, say you take a state. Just by way of example, I picked Ohio because it's in the middle. And so then you look at them together and you say, oh, that's really complicated, I can't read it. But that's okay, because you don't have to. Because what you're going to do is you're going to say, well, let's look at these ones. Because what I want to do is I want to start getting an idea of where are the real strengths and weaknesses for my given state, for Ohio. And so what you see is that in general, so Ohio's a pink one. In general, Ohio looks pretty good on these good ones. And in fact, it's pretty similarly better than the national average on all three of them. So what that would tell me is that if I were going to look at other areas of Ohio, I would expect Ohio to be above the national average on all of them. That's sort of my, that would tell me a little bit about where they are. So then I go back and I get into those states again, and I pull up then all of these for 09 and 11. We don't have this particular table for 07. But I also didn't want to show you for 07 because you would get very overwhelming. So before this gets too overwhelming, first we say, all right, well, we're going to cut out the really good ones. Okay, so this is basically taking the flip side of that coin. So before we said, okay, there were these three that were really, really good, and then I took out another one to make it a little bit smaller, but it still looks very overwhelming. So then we say, okay, we've got the very, very good ones are gone, and we're going to just cut down our range so that it's a little bit easier to see the differences. And so then we're going to spread them out a little bit. And it's still too overwhelming, but that's okay. We're not done yet. This is the ninja part. So bear with me, I promise. So now you look at these and you break them down, and then you take out the other ones. And you look at here and you say, well, what is the story? Okay, so this is the reason I'm showing you all the messy part is to show you that you can really dig through a lot of the data to get to what the interesting part is. And so normally, if I were presenting all this information, I would not give you all this messy stuff because it's too overwhelming. But I want you to be able to see that you can take the very overwhelming information and you can distill it down into something that people can actually wrap their heads around. And so what I did was I took this very overwhelming bit here and took out just that very first set of bars. The light pink and the light gray are the 09, and the dark pink and the dark gray are the 11. And because we're sort of working through getting to the more distilled version, it doesn't, you don't need to know all of that extra detail earlier because you're getting it down to the distilled version. So taking just that very top set where you've got the 09 and the 11, what is that telling you? Well, there's a story in there that you could totally use to inspire some huge action in a given state. So again, this is just as an example. But what it says is that there's been an increase in the prevalence of the model breastfeeding policies from 09 to 11. We've seen that both nationally, which is the gray, and in Ohio, which is the pink. But the story here is that if Ohio were progressing along just like the rest of the country, then both of those sets of bars should have increased the same amount. But what you actually see is that while the rest of the country was running to catch up with Ohio, in fact, Ohio didn't change all that much. So yes, it got better, but not by much. And you don't have to have an exact number and have, down to the hundredths or whatever, because for the normal people, that's not the story. They're totally overwhelmed by those numbers, but you know those numbers and you can look at them. So what we see here and what you could use if you were going to meet with the folks who might be able to influence whether the hospitals in your state have model breastfeeding policies in place, you could tell them this story, that there's more and more hospitals across the U.S. are actually implementing model breastfeeding policies. And we see with the mPINC survey data that in Ohio, if something doesn't get started now, Ohio's going to get left behind because the rest of the country is really charging forward. And that, that's going to perk up their ears. And then they'll see, and they're like, well, what do you mean? How is that happening? Well, here's what I see from the data. I see that in 2009, Ohio was way ahead of the pack. Ohio hospitals were clear leaders. Now, granted, you're in there's still the minority of hospitals that are doing this, which is another part of the story. But still, compared with the rest of the country, Ohio hospitals were clear leaders. And the model breastfeeding policies were present in 1 out of every 5 Ohio hospitals versus only 1 out of every 6 hospitals nationwide. But 2 years later, the Ohio hospitals don't really stand out anymore. So nationally, there was a 5 percentage point jump in model policies in hospitals, in the percentage of hospitals that have model policies in place. But in Ohio, it only went up by 1.7. So this is where, to me, the richness of the mPINC data really start to shine, because the story, if you're only looking at Ohio, yes, there is some story there that, yes, progress has been made. But in terms of how do you know whether this needs to be your priority or whether there's going to be other people you can reach out to for help, for example? Well, clearly someone's figuring it out because there's a whole bunch happening nationally. So how can I find out how to connect with them and do the same thing? So another example from that same very busy, overwhelming chart is just this one other piece of, helping moms get started with breastfeeding. And I really like this one because, if you think about who makes the difference and who decides whether you've got a model policy in place, that's very much a leadership and administrator, infrastructure sort of question. Who actually makes a difference about whether every mom who comes in that hospital actually gets hands-on help with breastfeeding? That is a nursing care issue. It's a very different issue. And there's a fabulous story to be told here. It's a very different story. So if you look at the data here, again, the light pink and the light gray are the 09, and the dark pink and the dark gray are the 11. And the pink is Ohio. The story here is that Ohio nurses are helping more moms than ever to get started with breastfeeding. And Ohio has transformed itself into some kind of national leader in nursing care, because they have skyrocketed ahead of the country. And then you're talking to the folks and it's like, what do you mean? Tell me more about that. Well, in 09, if you were a mom in Ohio, you had about a 50-50 chance of having your baby in a hospital where you'd have, a reasonable expectation that you would get the help you needed, hands-on help you need to get started with breastfeeding. Nationally, you had a little bit better chance, like 51%, but not by much. However, now in 2 years later, in 2011, the hospitals in Ohio have done some tremendous work, and the mom's odds of actually landing in a hospital where they're going to get the help that they need have improved dramatically, and so now it's up to nearly 2/3 of hospitals. And that's a story, because that is something that is not happening across the country. A third example of what you could do with some of these data, if it will behave, is, go back, that more needs to be done. And so basically in that first one you saw the pace nationally was faster, there was more going on nationally, bigger change nationally than in Ohio. The second one was the opposite. And not only was it the opposite, but Ohio actually leapfrogged over the national rate. This one is one where it's basically kind of a little bit stagnant. Now there is a little bit more progress in Ohio than nationally, but there's really not a whole lot of change that happened here. So again, this was at the bottom. This is the support, the post-discharge support, or step 10. And what you see is that hey, it's time to get started. We need to do something. So although Ohio moms have a better chance of getting the support they need than moms in many other states, not much has changed since 2009, and still the good support is less than, it's rare. It's not the norm. And so you can then go into some of the detail there of like, well, what does that really mean? And this one is, I think, in particular, a difficult one to communicate effectively of what does it really mean. And what it really means is accountability for that care and making sure that the discharge planning follows the best practices that we know are necessary. And helping them to really be able to understand that story, that these moms are really left out in the cold if they don't have some kind of connection. So in 2009, nearly 60% of hospitals across Ohio left moms to fend for themselves with any breastfeeding problems once they left the hospital. Nationwide, more than 2/3 of hospitals failed to make sure moms connected to the support and help they needed with breastfeeding problems. And 2 years later, not much has changed. Although it was better than the national rate, the Ohio moms were still more likely to have their baby in a hospital that did not provide her the discharge planning support she was going to need in order to be able to continue breastfeeding. So you can take these very overwhelming tables that have a whole lot of information in them, and you can really just get them down into something that is digestible and really tells a story without having to do super complicated analyses. It's not the whole story, but it's the beginning of the story. So again, this is one of those things that you think about when you're thinking about the different audiences that you're talking to, and who's determining the changes that are or are not happening, and who needs to hear what story. So some other kinds of things that you can do, use the data that we have up there to make the comparisons that you haven't seen before, and to find your story, because there is a lot of richness. As I mentioned at the very beginning, there's a lot of items that we don't really do a lot with. Now, right now, the only tables that are up there are the ones that go into the scores, but even that has more richness than what you see a lot of times in the reporting that we already have. So for example, if you want to look at some of the care practices by birth mode, you can look at, for just by way of example, tables 2.1 and 2.2 are the same item, the first feed, but they're broken out by VAGs and section birth. The other thing you can do that we have not yet been able to report, down to the state and community level is the going across the different years. So I purposely only used Table 8 because it only gives you 2 years, because showing sort of the sausage making of getting down to that distilled version at the end gets very overwhelming when you're showing 3 years in a row. But we, there's a lot to be said there. And show, you can pick either, the total score, you can pick one particular sub-score that you think is a big issue, or a single practice, or some combination of them. Another thing is to pick sort of your competitor state. Especially if you're talking to state legislators or other folks for whom sort of that is their focus group, so to speak, is making sure that you outpace whatever your peer state is. All of those data are up there. And then another is to think about doing basically the same kind of thing that I did through this example, comparing Ohio to the U.S. You can do that comparing individual facilities to the state. And there are a lot of different ways to do that, and there's a lot of different projects that have gotten a lot of mileage out of that in order to be able to really say, well, we are a higher need area, or we are doing better in these different ways, because we fully recognize that the state is not homogeneous and that there's huge variation across the state. So those are just some ideas of ways that you can dive in that are manageable and not too scary, so for your sort of intro ninja work. But really, as you're thinking about these things, as a coalition, as a group, I really think the most important thing is to, be confident about being able to use these data, because they are not scary, they're not overwhelming. You have to just, make sure you tell them who's in control, and be creative with what you're doing, because there's a lot that you can get out of these data if you think about it in some different ways. But also to be precise in the analyses that you're doing and the messages that you're trying to get out. And be thoughtful and fearless and fix everything. That's all. So this was just a very, quick and dirty, so to speak, little bit of sort of some of the stuff that we have up here. But in addition to thanking all of you for everything that you do in your coalitions and your state health departments, it would be completely inappropriate if I didn't thank the actually, ironically, room full of people who are all squished into one little office here, but especially Kriya Perine, who's sitting literally over my left shoulder, who is really the brilliance behind this abundance of tables, because without her, they would really not be up there, and then you wouldn't get to play with them, because I would be bald and have ripped out all my hair, that's for sure. So, so yes, that is all I've got on that, and I will turn it back over to Megan and Kinkini.
Thanks so much, Katherine, and what a great way to think about practical use of the mPINC data. And our next presenter is Emily Lindsay, and talking about the breastfed beginnings. You're on, Emily.
Good afternoon, everybody. I think it's afternoon where everybody is, at least, at this point in time. It's always nice to listen to Kat because she's so hilarious when she talks. And I know sometimes we get a little dragged out on the phone, so bear with us for a little bit. And as Kinkini said, we do have some good news, and so you'll hear about that later on in my talk. Briefly, I'm with the United States Breastfeeding Committee and the Breastfed Beginnings Project. And what is breastfed beginnings? Everybody kind of has a question about that. I think at this point in time, you guys are familiar with the slide about who we are with the USBC, but a lot of people do not realize that the Surgeon General's call to action to support breastfeeding actually identified the USBC and its affiliated state coalitions as leaders to implement the Mini-20 actions. So if for some reason you haven't gone through that report yet, I highly recommend going through to kind of figure out different places where your coalition can assist. And breastfed beginnings definitely falls into that. We have 3 different areas that we're currently working on and moving forward with this project. The first one is to convene an advisory committee on the community support for breastfeeding. And the second is to facilitate the building of a community, basically community connections to support these participating hospitals. There are currently 89, to get them in partnership with our state coalitions if that's not already happening. And then also the third very exciting area that we're going to talk about at the end are recommendations to electronic health record vendors. Some of you may be more familiar with EMR as opposed to EHR, but actually the correct term is EHR, so you'll hear us refer to it as that. On this first area with the Advisory Committee Support to Breastfeeding, the basic goal to this is to get a group of national organizations together who have been identified to be able to make these connections between hospitals and communities and how we can really promote then these 6 months of exclusive breastfeeding. Members come from diverse areas, hospital settings, outpatient healthcare settings, community, and even governmental agencies. And to be able to leverage their influence together and individually to really start strengthening these connections that need to happen between community groups and resources in these participating hospitals. And then also looking at and sharing information with these hospitals and the communities as they start to implement those steps 3 and 10 in the Baby Friendly Hospital Initiative. And then also providing the guidance on the development of the systems to advance the continuity of lactation support between hospitals and any outpatient healthcare settings and community settings, so that we know that mothers are in fact being educated before they deliver, as step 3 calls for, and then as well as being taken care of once they're discharged and they know where to find that help and be able to access that on a consistent basis. Participating in something like this is great practice for state breastfeeding coalitions, and we want to use this advisory committee to really develop and advance models of partnerships that will make education about breastfeeding for both individual and group counseling available to pregnant women, and be able to advance these models of partnership for continuous follow-up care for then others to use. On the hospital community connecting, the importance of that around step 3 and 10 is that it will be both with the state breastfeeding coalitions and then where appropriate also with our local community coalitions, and to develop to work towards making these systems for that continuity of care like we were just talking about, specifically though with these Best Ed Beginnings collaborative hospitals. And again, there's 89 of them throughout 29 states. And the objectives that we're kind of working for in there are really reinforcing what these coalitions have already started doing and these community efforts to work with these hospitals and develop these programs for education if they're not already there, and then also reinforcing just the efforts to, again, follow up with these families, because we know that it doesn't just stop once they leave the hospital. So the exciting part about that is that this week on the 15th, the United States Breastfeeding Committee is actually going to put out a request for information to the 29 states and their breastfeeding coalitions, and we're going to start talking a little bit about that. And I'm sure many of you will have many, many questions. Remember that Kankini and Megan can see these questions as they come, and then a lot of them honestly will be answered as well just in the request for information that comes out this week. But briefly, I do want to cover what the funding opportunities are and take a minute to go through that. So there's 2 different streams of funding that are going to be available to the state breastfeeding coalitions. The first one is what we are referring as implementation funding. There's a total of $116,844 in this category. Now, I want to make it clear that this money is going to be available to all 29 state coalitions who currently have Best Ed Beginnings hospitals in their boundaries, but that all 29 state breastfeeding coalitions will get some level of funding out of this pot of funds, and that they'll be dispersed on a scaled level. So in other words, not just equally between the 29. But then there is a second subset of funds for capacity building for a total of $15,000 that will not necessarily go to all 29, but instead a subset of those who really have needs that are identified in this request for information on having the need to build capacity. As far as the timing for this, like I said, this Friday, February 15th, is when it is actually going to be distributed via the USBC website, and also the Coalition Designated Contributors e-list. If for some reason you believe that that contact person is out of date, please go and update it. You can do that via the USBC website. And then responses to this information are going to be due on March 1st by 5 p.m. Pacific Standard Time. And then you'll be notified about funding decisions by March 27th. And then basically the period for when the funding will start and end is going to be April 1st to September 30th. And again, I'm sure there's lots of different questions about, well, what are we supposed to do, or what are we going to do to move forward? And a lot of that will be covered in just the basic request for information proposal. But overall, I want to then go through what the USBC will be able to do within this funding stream. And we will be providing customized technical assistance for state coalitions. So if you need assistance, that's what we're here for. And then also provide training and network opportunities for coalition leaders. There's many different ways we can do this, but there's a couple different items that are already happening both prior to Breastfed Beginnings and now within Breastfed Beginnings that can assist with this. Part of that is to support the continued expansion of the Interstate Collaborative for widespread implementation of the 10 steps. If you are not familiar with that is, go ahead and pull up your little Google bar, because I know half of you are already doing it, and go ahead and put in the Interstate Collaborative under Carolina Global Breastfeeding Institute, and you will find a website via that. And then also coordinate with the Advisory Committee on Community Support for Breastfeeding. That is the committee that is being put together currently with the Breastfed Beginnings program. We're very excited about that. And then also hosting quarterly webinars and discussion to share and disseminate information about best practices and lessons learned between coalitions, between hospitals, between community groups, because we learn best from those who are in the trenches with us. And then, of course, select and compile and actually publish 2 to 3 case studies of best practice regarding community connection. So if we see something that's working very well and we'd like to highlight that, this will give us an opportunity to do so. And then, as always, supporting and preparing for the action period call on community connections. And this is going to be a phone call for both participating hospitals within the Breastfed Beginning Collaborative and then the state breastfeeding coalitions that support them. The third really exciting part to the Breastfed Beginnings project is in the EHR, like we were talking about, electronic health record recommendations. And basically, anybody who's ever worked in, whether it be an inpatient at hospital setting or even outpatient where electronic health records are becoming commonplace. See, I even slipped up on myself with EMR. The goal is to identify and describe best practices that will allow maternity hospitals and the EHR vendors to learn from the implementation of early adopters. So basically those who are already doing and sharing and really teaching us. And although there is such great variability between many facilities, there typically is always a bell curve of kind of the lessons are learned, and we would like to then be able to learn from that. 2 specific types, though, that we're interested in looking at are the best practices for clinical implementation side. This is literally, what do I need to do to accomplish the task of entering critical patient data in a timely fashion? And then the technical side, which is what format, what vocabularies, and what structures are being used, and what limitations and functionalities of the systems are being addressed. And the second part to that of the whole EHR process, because we can tell you that it is quite the process, has been engaging with a consultant who is very familiar with this, and organizing and convening an expert panel of infant feeding and data collection experts so that we know what data needs to be pulled out. We know what's important to the process and what's valuable to both hospitals and vendors and insurance companies. And then presenting and advocating for the adoption of these recommendations by the major software vendors to include the outreach to the appropriate federal authorities, and of course doing this in partnership with key leaders or stakeholders. And then the last part is actually designing and implementing a communication plan. And this includes getting information out to the hospitals that this process is underway, periodic updates to them about what's happening, where it's going, and then, of course, promotional, the final recommendation. So we have a lot of things going on in the Breastfed Beginnings project, and all of it is so great for coalitions to be moving forward and really getting an upper leg to being able to help their hospitals with this process, kind of like Kat was talking about, being able to move forward, use your value, and help fix hospitals, in her words. So I encourage everybody to then go to the USBC website that's specifically geared towards breastfed and coalitions. The link is on the last page. But for those of you who maybe don't have it up, it's www.usbreastfeeding.org, and then a /bestfed and then coalitions. And as I stated again, the RFI is going to come out this Friday, the 15th, and has many components to it that will answer lots of questions that I'm sure you're all buzzing about. But I encourage you to start thinking about that now and keep your eyes open for that this Friday. And if there's any questions, it will have my contact information and be able to answer a lot of other information. So now I'm going to turn it back over to Kinkini, and I know they have some important announcements, and then can field some of the questions that have popped up.
Thanks, Emily. And now we have some time for a few questions.
Thanks, Emily. This is Megan and Kinkini here. We are actually together at Learning Session 2 in Austin, and so I just wanted to add, because we are very fast and furiously working on this RFI for you, just wanted to add the note that the website that you see in front of you that Emily just mentioned, that is the web page where on Friday we will post the RFI. It will also, of course, be emailed out on our listserv, but just so you know that link is not yet live, but that is where it will be residing. So we're actually going to take a few questions now before we turn it over to announcements. And one I will just mention is that we had a couple of questions about can folks link to this recorded webinar if you'd like to promote it in other venues, and yes, you certainly can. The main landing page for the webinars, which you had in your confirmation emails, it'll also be included again in your follow-up email that you receive in just about an hour after the webinar ends. That landing page can be shared with anyone. The recordings are available as well as the slides and handouts for everyone. So please do share that information widely. Just a couple of questions. I believe these first couple of questions are for Kat. So Kat, just make sure to unmute yourself before you respond. And this is a question about any ideas for improving long-term tracking of data from hospitals, and any feedback or ideas that you might have on long-term tracking over time.
I'm not exactly sure tracking of what. I'm reassured that Larry has a quizzical look on his face also, because it's not just me. I guess I imagine maybe the person means data beyond what we are collecting in mPINC, so maybe their own clinical data, but I'm not really.
Yeah, it may be, and if that person could type in, actually, can I also add just a reminder in case you missed at the beginning, you can ask questions. We don't have questions verbally, but you can ask questions by typing them into the questions box on your webinar screen. So if you go to your webinar control panel, there will be a little box called questions, and click the plus sign there, and you'll be able to type a question into the box. We do have a couple of other slides coming, or other questions coming in. Let's see.
Well, so just one more little follow-up. So as far as the mPINC data we have back to 2007, and those are all on the website. The only piece that we don't have back to 2007 is actually the example data table that I gave, because we created that for that initially for that MWR. CREA created that. But all of the other mPINC data we have back to 2007. Yeah, I don't want to go further than that, not knowing more detail.
Yeah, I think that's what it was referring to. A couple of questions about the funding. Is there going to be funding available? We have a couple different questions I'll throw to you, Emily. One is there going to be funding available for hospitals directly? And the second question about funding is whether the funding is available for state coalitions or local. You could probably square that circle for us.
Sure, absolutely. So that first question is funding available to hospitals? No, not at this time. This funding is specifically directed to the state breastfeeding coalitions, which kind of then wraps me into the second question. state breastfeeding coalitions, as needed, are encouraged to work with local breastfeeding coalitions, but the funding itself is geared at the state level. There will be lots of information in their request for information and then in the deliverables about how they can work with locals, and there may be a process in there of working together as far as the money goes. But financially speaking, the subcontracts are geared and aimed towards the state breastfeeding coalition there and the registered state breastfeeding coalition for each site, or each state, sorry.
Great, thanks. We also have questions. Can you elaborate a little bit more on what the funding will be used for the coalition?
I can give you a little bit of background information, and then the key deliverables will be very spelled out in a request for information, but it really is about creating the connection between state breastfeeding coalitions and the hospitals within the Breastfed Beginnings Collaborative, identifying key liaisons who can both assist the coalition in building that network, and then also vice versa in assisting the hospital with community groups and agencies, and looking at where resources exist and where they do not exist. In other words, where are gaps and the barriers to identifying that. And all of those objectives will be spelled out very clearly.
Awesome. We have a couple of different EHR questions that I might just address. One is about at which point should we tell hospitals about the EHR info? And yes, we do know that many places are struggling with this. I will tell you this is on a very, very accelerated track, this work. So there is no reason that you cannot already begin to tell hospitals that recommendations are forthcoming and that USBC will be working on this. And again, making those recommendations to the appropriate federal authorities and to the vendors. At the moment, the early stage work that is going on is actually identifying several, as Emily said, several best practices, whether it is with vendors that are doing this particularly well, or whether it is hospitals that are doing data collection particularly well. So if you do think that you have a good example, a good model that we should be learning from with our expert consultants and expert panel, please do let us know. But again, it's going to be in a very accelerated pace over the next 6 months, really. So as we said, we will be getting out early alerts that this process is underway, that we are working as fast as we can, but of course we won't have information immediately available, and we do recognize that folks are already struggling with it. But we do want them to know that help is on the way and help is forthcoming. Another question on the EHR is that will the information be available to all states and hospitals regardless of whether they are included in the Breastfed Beginnings? And that's a very good question. Although this component is funded through our partnership with Breastfed Beginnings, USBC's work in this area, it is not in any way specific to just those hospitals. This will be available nationwide to any and all comers. All vendors and hospitals that we can reach and that are interested in this information will be able to receive this. It will be public information available to anyone. So a very good question, although it is funded through this initiative. I'm going to just take one more question, maybe one or two questions here back to you, Kat, on the data. There's a question on, is there anywhere available statistics at the county level? And there's also a question, can you just clarify this, when will the 2011 data from mPINC be available? So two questions. One is, are there statistics at a county level, especially breastfeeding and exclusive breastfeeding statistics? And then the second question is on the 2011 mPINC data, which I believe is already available.
So to the first question, if you live in California, you get the mPINC data at the county level. That's one of the analyses that they did. So move to California. No. And I think it's a great question because it's a good example of how states can learn from each other and kind of adopt some of the same strategies. So the folks in California did some very cool analyses where they sort of recut the data, really because California is essentially its own country. So the state reports are essentially at smaller units. So those kinds of analyses are the kinds of things that that are possible when state health departments work together with some other folks and kind of come up with a plan of how they want to use the data. And we have those, of course, 83% of all the hospitals in the U.S. participated in the survey. So a lot of different analytic options are out there, and it's a good thing to think through and discuss with us if there are analyses that you think are the linchpin of what you need in order to move some of your efforts forward. And you can email Kriya. Actually, the mPINC, it's a good opportunity to mention the mPINC mailbox, actually. So mPINC, not K, at cdc.gov is our mPINC mailbox. And if you have questions or other things that you'd like to know about the data in particular, that's a really straightforward way to get in touch with us. The second question about the 11 data, I used the 2011 data in the presentation today. The state scores were in the report card that came out over the summer, and the state and facility type information is all up on our website. And if I had even more time, I would have talked about all of the tables that I used today came from sort of that right-hand side of the page. On the left-hand side is a whole other layer of richness where we've got all of the facilities broken out by facility type. So you can look at public, private, teaching, military, you name it. Everything under the sun is on the left-hand side. So I have a feeling that's not really what the person was asking about the 2011 data. They're probably asking about the state reports. But since they didn't ask that, I don't have to answer that question. No, they are, they're not out yet. They're in clearance. That's
got it. Thank you, guys.
That's not nearly as nice an answer as the rest of it.
Yeah. Well, I'm gonna turn this back over then to you guys out at CDC. We'll move on to announcements, and I believe CDC has a few announcements, and then Kim Kinney will wrap it up with a few announcements from USBC. So Larry, take it away.
Okay, thank you, Megan. So I have three announcements. The first is that in follow-up to the presentation today on mPINC for 2007 through 2011, in today's Federal Register notice, we are announcing the data collection for 2013 and 2015. This is a 60-day notice open for public comment. So any of you who are interested in providing comments on the utility, the burden, the necessity of collecting these data in mPINC, you are welcome to provide your comments. The information is all there in the Federal Register notice that came out today, and I believe that Megan and those at USBC will be sending you a specific link. It's a complicated link, so if you just click on the link that you get through the website, you can see the actual announcement, and all of the instructions for how to provide comments are there on the website. The second announcement is that today's issue of Journal of Women's Health has a lead article from a report from CDC about our maternity care practices work, talking about some of this work on mPINC, but also many of the other efforts that we have going on in support of maternity care practices. So it's nice to be able to lead off that issue with issues around breastfeeding. And finally, I hope that all of you saw the news last week about our report on progress in increasing breastfeeding and reducing racial ethnic disparities in the United States. This highlights the data from the National Immunization Survey from 2000 through 2008 and showed really very good news. We've shown sustained progress in our rates of breastfeeding at initiation, 6 months and 12 months. And we have reduced the disparities between blacks and other ethnic groups, and that those disparities, while still there, are certainly getting better than they were before. So a lot of good news there to report, and we got a lot more media attention than we had anticipated with that. Particularly want to congratulate Jessica Allen on our staff for pulling that report together. So that's all the announcements I had today. Thank you.
Thanks, Larry. And I have the best job because I get to work with all 50 states and the territory regions and tribal regions. So you've got emails from USBC in the last couple months. Thanks to our increased capacity, what we're going to be doing is a comprehensive needs assessment for all 50 states, territories, and regions. And the purpose of this needs assessment is to examine current structural models of coalitions and to see where our coalitions are in their stages of life cycle development, to collect information on activities of state coalitions, and through our study of all 50 states, kind of identify what are the markers or elements of effective coalition. So how will this needs assessment be done? We have online surveys that will be going out, and there are two versions of the surveys. One is a leader survey that either designated contributors or coalition leaders could complete, and we need about 1 to 3 per state. The second survey is a member survey to be completed by a representative sample of state coalition members. So we are hoping that, we have at least 4 to 7 per state, so that we can get some input and feedback from your different members, from the hospital sector, from public health, mom, community. So hopefully that will give us some good data. The other part of this needs assessment is phone interviews that I will be doing with key stakeholders. And this will give a lot of really good information about what your coalition priorities are, what are your strategic goals, what projects and initiatives you have, what kind of partnerships and linkages you have, and how ready you are to seek and utilize available funding opportunities. And the whole purpose of doing this needs assessment is to kind of find out where the coalitions are in terms of their capacity, but the best thing is that this will really give us information about how to customize the technical support for each state. So the surveys with the instructions and some detailed information will be sent to the 3 designated contributors on file with USBC. And I also wanted to let you know that it doesn't have to be the DCs who have to be the folks to respond. So be thoughtful, figure out who would give us the best possible feedback about your state coalition and about to be able to tell us your strengths, your challenges. One thing that we want to do is learn about your needs, but also learn about the kind of collective expertise you have, so we can tap into some of your strengths in the future initiatives that we will be hoping to do. So each of these surveys should not take more than about 20, 30 minutes to do, and we expect the phone interviews to be about 60 minutes long. So small investment in time and can yield really big results, and this is, the time is right, the time is now, and we have this capacity for the kind of partnership that we wanted for so long between the states and USBC. And we hope that you will respond to the surveys, give us candid, thoughtful feedback, and that will help us serve you better. So thanks so much. And that's the end of our national webinar. And for those on the regional calls, if you're one of the 5 from your state connecting to the regional call, you can disconnect from this call, hang up, and then dial into the regional number provided by your DCs or proctors. And also to let you know that you should get an evaluation within an hour. So we'd love to hear your feedback. And as always, all our materials will be on the website coalition page. And thank you. We couldn't do this without you. Thank you so much for all that you do. And I really look forward to working closely with all of you. Thank you.